is about plastic surgery for MRCS. Let's go for the burns. What about burns? They are defined according to the depth. This is important. Depth determination of the depth of the burn is important. Epiderm, if the burn is limited to epidermis, then superficial dermis, deep dermis, and full thickness. So there are three parts: epidermis. This is dermis has got superficial and deep, and full thickness. So what is the difference between epidermis and dermis? Color is red for all. One, two, three. One is only epidermis. Second is superficial dermis. Third is deep dermis. So one is red. Here it is red plus blister, red plus mottle. The difference is blisters can be present in superficial dermal burn also. So superficial epidermis and dermal burn, there can be blisters, mottling in the deep dermis, and full thickness burn is white or black. So it is because of charring. That is full thickness. Second is painful. Epidermis is definitely painful. Superficial dermis is also painful. Deep dermis is less painful, and full thickness is painless. This is the difference in full thickness, and this you can call as partial thickness. All these are partial thickness. Partial thickness when there is only epidermis burn. So healing if epidermal burn, maybe sunburn or something like that, it is within 1 week. Superficial dermis takes 2 weeks, more than 2 weeks, and scar can be there in deep dermis, and there is definitely scar. Counting rule in 9. For epidermis you don't go for rule of 9, how much percentage, because it is just a very superficial layer. From superficial dermis, from dermal burn you start counting rule of 9. So this is Wallace rule of 9. You have to measure this. Extremity total anterior posterior is 9. Head neck total is 9. Leg is anterior 9, posterior 9. So 9 front, 9 back. So total 18. Now divide the chest. Upper is chest, lower is abdomen. Just think of upper torso, 9 anterior, 9 posterior. The same is 9 anterior, lower torso, 9 posterior. Perineum is 1. So all these there are 11 nines. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 nines and 1 1. Measure second and third degree burns. Rule of nines. A patient, it is for the second and third degree. So degree of burns. A patient's hand is equal to 1% of the body. This is important. This is 1%. Total hand. Now what is the difference in children? The head and neck is 18. Rest 18 18, and legs are reduced. Now 4 4 are reduced in this. 14 14 means total 8 is reduced out of this. So 9 plus 18, perineum is also reduced here. Initial management, you have to remove person from the burnt area first. Definitely. ABG according to ATLS, rinse burnt area with water in 15 to prevent further damage. When to transfer patients to the hospital? When you are hospitalizing the patient, more than 5% in children, more than 10% in adult. So 5% rule for children, 10% rule for adult. Site of the burn, face and perineum. If it is there, you have to admit the patient to the hospital. Electric, chemical, you have to transfer patient to hospital. Full thickness, deep or circumferential. Resuscitation fluids, more than 10% in children, more than 15% in adult. IV fluids. Fluid is Hartmann. This formula is coming most of the time. ATLS says 2%, 2 into percentage into surface area. Do not calculate for first degree. First degree burn is superficial. Divide into 2 halves. 1 half is in first 8 hours. So whatever percentage, second half in the next 16 hours. So first 8 hours means if you are dividing by 2% of burn into weight will give for first 8 hours. This is straightforward. And if you want to make it for 24 hours, you have to multiply by 2. So ultimately you are multiplying by 2 and dividing by 2 to make for the 8 hours. So this is the way. So management of the burnt area. Hmm? How to follow up? This was about this follow up. Urinary catheter 0.1 ml for per hour has to be for adult and 1 ml for the children. CVP is to measure. Management of burnt area. Superficial dermis but topical superficial dermis. Superficial dermis is there. Antimicrobial silver sulfidized dressing. Deep dermis full thickness. Excision split grafting is required. Complication of burn. Facial burn may lead laryngeal edema. Intubation is indicated. Facial burn. Circumferential chest around. Ischiotomy is indicated. Around the limb may cause ischemia, urgent ischiotomy. Around the limb, ischiotomy and fasciotomy. Acute gastric, this is the question. Integration of question. Ischiotomy is the question. Acute gastric dilatation, upper abdomen, so rise to be indicated. Curling is the question. For burns, you get edema because of hypoalbuminemia is a question. Grafts, more dangerous complication is sepsis. This is again a question. So inhalation of burns, CO poisoning, burn tooth and all that, mechanism of CO2 250 times. This is a question, it's true. So displaced oxygen from the air causing hypoxia. Seen hemoglobin level more than 10%. Airway intubation is there for carboxyhemoglobin. Whenever there is CO poisoning. Treatment by hyperbaric oxygen. This is the question. Chemical burn, acids are more painful. Acids are more painful. Alkali is deep. So painful is acid, alkali is deep. Should be brushed and irrigated with water. It doesn't cause neutralization. It should be brushed. So irrigation should not be done. So no neutralization before irrigation. So neutralization, don't try to neutralize with the water. Just brush it first. Chemical burns. So if you try to dilute it, it is not useful, or rather it can cause harm. That's why chemical burns, first brush it, then electrical burn, danger of heart, it is immediately muscle rhabdomyolysis. So what about the skin lesions? Vessel, sun exposure. This is the most common, 90% of the patients because of immunosuppression. Classical nodular region showing telangiectasia. This is mentioned in the question. Not metastatic. Incisional biopsy for diagnosis. Incision biopsy. Surgical excision with 3 to 4. This is enough. Completeness of the excision. This is again question. Radiotherapy is for unable to undergo excision. And while compared to squamous cell carcinoma, immune suppression. Patient is on immunosuppressive therapy. Bowen's disease, virus, HPV virus, chronic wound scar burn, marginal ulcer is also squamous cell carcinoma. Keratinizing tumor. This is question. Metastatic to lymph node. This is question. Incision biopsy for diagnosis. Surgical excision 4 to 6 margin. Lymph node biopsy FNAC for positive. This one is the question. Melanoma again, non-exposed area. So skin lesions may be asymmetric. A, B, C, D for this. Asymmetry, border irregularity, color changes, diameter, elevation, enlargement. Irregular macule nodule patch, Bowman pigmented may cause metastasis to lymph node. This is important. This can metastasis to lymph node. Well, basal cell carcinoma is locally invasive. Excision biopsy with 2 mm margin. So Breslow gives the depth of the lesion. Depth of the lesion is important. 0.5 to 1 centimeter is in situ. Less than 1 centimeter is 1 millimeter thickness. Less than 1 millimeter. Sorry, 1 centimeter means 10 mm. If thickness is less than 1 millimeter, then margin in situ means it is not deep. So even 1.5 to 1 centimeter margin enough. If it is 1 millimeter, 1 centimeter margin is required. 1.24 millimeter, 2 centimeter margin. More than 4, more than 3 margin is. This is margin of excision, and this is depth. 1 millimeter, 4 millimeter, more than 4 millimeter. In situ is not deep, it is limited to cells. So 1 centimeter margin, 1 centimeter margin, 2 centimeter, 3 centimeter margin. There are different types. Superficial spreading, nodular, lentigo-maligna, acral. So what is this among? Most common is superficial spreading. SS. Superficial spreading, more common and best prognosis. Present on the back, elderly, rapid growth, black patch, nodular. Bad prognosis. Most bad is nodular. Once it becomes nodules, it has got bad prognosis. Now, lentigo maligna, large brown patch on the face. If it is on the face, lentigo on the face, cheek. It has also good prognosis. Elderly pigment on hand and foot, acrylentigerous. It is bad prognosis. Palm and sole. Palm and sole, pigmented, bad. Pigmented face, lentigo, good. So good is superficial spreading and lentigo, and bad is nodular and acral. Benign skin diseases, sebaceous, you see the punctum. Scalp is common, face, back, palm, sole. Nodular lesion, foul smelling discharge, and cheesy material. If not infected, if not infected, excision. If infected, drainage. When you see hair follicle, it is pilar cyst. Keratoacanthoma on the face, there is hyperkeratotic core rapidly growing and sloughing off, growing and vanishing. So excision is there. It is benign. Acanthocus nigricans, this is brown to black patches, cause endocrine, diabetes, Cushing's, insulin resistance, familiar, autosomal dominance, paraneoplastic and gastric cancer. Dermoid cyst, this can be epidermoid tissue, lines, embryonic, angular dermoid, or midline dermoid. Midline dermoid, it can be seen above the hyoid bone, above hyoid. Dermoid. This is seborrheic keratitis. Seborrheic means something related with the seborrheic warts. It is itchy, shave biopsy, the treatment and cryosurgery. Mainly dermatofibrosarcoma. Again, the question is dibrofibroma. There is mainly trauma. History of trauma is there. Painful papule. Then it is granuloma. Pyogenic means there is tissue trauma. Granulation tissue is there. Epidermoid cyst. Again, trauma. History of trauma is there. Epidermoid, dermatofibroma. Epidermoid and dermoid cyst. Two are different. Epidermoid inclusion, epidermis at the site of trauma. Something has got inside. There is injury. And there is trauma larger than appearance. Itchy blisters with celiac disease, dermatoherpetiformis. This is Crohn's, pyoderma gangrenosum with the Crohn's disease. You get surrounding. So what are the mouth lesions? You see a sub bluish cystic lesion under the tongue. One thing. Second, this is mucocele, just swelling in the inner aspect of the lip. Aphthous ulcers, stress ulcers. Reddish patch, velvety on the tongue, erythroplakia. Hairy leukoplakia, immunocompromised. Squamous cell carcinoma of the tongue, most common, older smokers, alcoholic, enlarged cervical lymph node. Peritonsil abscess, quinsy. Diphtheria, membranous enlarged patch, midline, bleeding on removal, this patch. What are the different types of biopsies? Incision, superficial lesion, squamous cell carcinoma, you take incision, basal, used for deep-seated lesion. Usually while doing surgery and we can't do excisional biopsy. Punch biopsy is for Paget's disease and venous ulcer, marginal ulcer and Paget's. Excision biopsy can be done for melanoma, excision, for benign lesions, sebaceous cyst. True-cut biopsy is done the breast mass, thigh mass, abdomen, retroperitoneal mass, which are deeper. Seborrheic warts, you do only shave biopsy. Thyroid, you go for fine needle. So what are the types of graft? Graft taken from the same person. Skin grafting is auto, iso is same, identical twins. Allografts from one different identical twins from one person to another. Porcine is the animal graft. This is a skin grafting. It is a process of transferring piece of skin without blood supply from one side to another. Totally skin graft, healthy vascular tissue. Split thickness and full thickness consists of epidermis. It is having epidermis and part of dermis. Dermis and all dermis, full thickness. Donor site heal with reepithelialization. Requires here donor site closure. Large areas donor, limited donor area. In burns mainly in posterior auricular, nasal, anywhere post auricular skin and groin. Full thickness graft removed. Flap vascularis, unit of tissue is moved from donor to recipient side. Examples of flap is radial forearm. This is the radial forearm perforating radial artery. Lateral arm flap on posterior collateral radial artery of profunda femur brachii. Anterior lateral thigh branch on the lateral femoral circumflex. Lateral femoral LFC, anterior lateral thigh. Then transverse tram flap is on the inferior epigastric. This is called as tram. Inferior epigastric artery. Latissimus dorsi, latissimus dorsi flap, thoracodorsal. Thoracodorsal. Wound closure. It is direct apposition of the wound and even clean wound. Delayed primary is done when the left open for fear of infection. Second intention, AJS wound contraction, drainage of abscess, perineal abscess is by second intention. Skin reconstruction, scalp, you can get closure due to high blood supply. Primary can be done and rotation flaps can be done. Nose, definitely this has to be done. Immediate debridement, let it heal by second intention, then definitive repair by pedicle graft. So let it heal by second intention. Defect over the nose after basal cell carcinoma, pedicle graft. Immediate debridement and let it heal by second intention, and then pedicle graft has to be there. Laceration of the face, simple suture by simple dressing. Anus heal by second intention. Peritibial without bone exposed, debridement, vac and delayed split thickness if there is periosteum. Bone exposed, you need flap. Heel pressure, debridement, second intention, pressure dressing. Split thickness, mesh graft. Now injury to the nail. Nail plate formed of the nail bed at the rate of 0.1 millimeter per day. Nail bed germinal matrix. What are the parts produced by the nail plate? Germinal. Sterile matrix adds squamous cell. Dorsal matrix adds luster to the nail. So it has got germinal matrix. AP lateral X-ray, then if subingual hematoma less than 50% conserve and may need drainage of them. If nail bed laceration, subungual hematoma absorbs suture 60 and nail is replaced back a splint, and if not available use a splinter. If loss of sterile matrix means squamous cell which is added, may splits come after adjacent nail bed and loss of fracture distal nail may need fixation. So nail bed should be fixed, that is the main thing.